Let us now look into what is the current scenario of kidney transplantation in children in the world. In fact, children comprise only 5% of all kidney transplant recipients. Over the years in last decade, the rate of kidney transplantation in children has increased substantially because in many countries, the allocation of graft, children get high priority. Living donor transplantation is still happening in majority of cases, and in majority of cases, it is from mother to son. Now, look into the scenario in India. The scenario in India is quite gloomy, and very few centers have dedicated pediatric kidney transplant units. About 62% of adult nephrologists handle pediatric kidney transplantation. Pediatric nephrologists are a very rare species still, and only 67% of pediatric nephrologists also undertake kidney transplantation. There are only 3 government institutions who offer pediatric transplantation. All others are private hospitals or individual best practice. The rate of preemptive transplantation is still very low, and very few centers undertake more than 5 transplants a year. So why is it like that? So there are a lot of barriers in kidney transplantation in children, and let us discuss about this little in detail in few slides. So the barriers in kidney transplantation in children could be a knowledge barrier. There is a lack of access to appropriate healthcare, social barriers, economic barriers, medical surgical barriers, and policy barriers. We will not be discussing about the medical surgical barriers in detail, but other things we will discuss in great length so that we will be able to know what are the barriers and then how can we overcome these barriers and increase the transplantation rates in children. The knowledge barrier, very less training is happening in undergraduate level and postgraduate level regarding kidney diseases in children. So the doctors coming from the medical schools are not getting adequate training about kidney failure in children. Also, very much less or very scant information is available to public regarding kidney failure care. And because of that, many prevalent myths are there about kidney failure. Also, there is apathy towards children by family, society, and government for various reasons. There is also very acute lack of access to appropriate health care for children with kidney failure. Why? Because very few institutes are competent to handle children with kidney diseases, and distance to healthcare center equipped to handle children with kidney failure is it's a very important factor. As the distance increases, the dropout rate increases, and care of the children doesn't happen. Also, there is lack of support by the state considering it is a chronic disease. There are many social barriers about kidney transplantation in children because of various myths and practices still prevalent in society. Also, there is an issue of neglect, especially in the girl child. There is a lot of fear and apprehension about transplantation. What will happen to the donor after transplantation? What will happen to the child after transplantation? How long they will live? Will there be second or third kidney transplantation will be required or not? And based on that, lot of exploitation happens about as there is knowledge gap in kidney failure, a lot of exploitation happens in the form of alternative form of therapy and other people in the society. Now, coming to the most important barrier is the economic barrier, because the cost of end-stage kidney disease or kidney failure is quite high. If we see the cost of dialysis, if it is in hemodialysis, it varies from rupees 1,000 to 5,000 depending on the institute where you are getting dialyzed, depending on whether it is state sponsored or not. It varies from rupees 1,000 to 5,000 per session, and the child has to come for 3 times per week for dialysis. Then you can imagine what is the cost involved in it. And for peritoneal dialysis, it is roughly equal to 1,000 rupees per day. Not only that, the children are very high risk. They are the sickest the children available for treatment. They get frequent infections. They get admitted frequently, and these frequent admissions add to the cost. If we look at the cost of transplantation surgery that is prevalent currently in India, the cost of transplantation surgery varies from rupees 3 lakhs to 10 lakhs depending on where you are getting transplanted. After that, the child should be on lifelong medication. So the cost of end-stage kidney care or kidney failure care is quite high. Most of our patients are not covered by insurance, not covered by government schemes, and they afford it by out-of-pocket expenditure. So this is one retrospective study done in PGI-MER Chandigarh in adults. They found that kidney transplantation was associated with catastrophic out-of-pocket expenditure. About 54% suffered from severe financial crisis that led to job losses, that led to school dropout, and many families also sell their properties to get their dear ones dialyzed, get their dear ones transplanted. There are some policy barriers also. Government of India and NATO policies are still adult oriented, I would say. Like, for example, the policy of requirement for registering a child for deceased donor waiting list is still similar to adults. That is, the child should be on dialysis for 3 months just to get registered and to be wait listed in a deceased donor program. And this is very crude because we know dialysis is very painful, leads to very poor quality of life, and even the child can succumb to death in these 3 months. So to know about the barriers in low resource setting, this was a retrospective study done at a single center at St. John's Hospital, Bangalore. They tried to find out what happened to about 155 children who presented with end-stage kidney disease. What was the outcome of follow-up of the children? And very unfortunately, you can see there are very high rate of dropout, like 71 of almost half of the patients dropped out in the follow-up. They turned as a loss to follow-up. That was 65 children discontinued treatment and 19 children died. Out of 71 children, 41 children agreed for the transplant evaluation, and ultimately 28 children got transplanted. 11 children were still waitlisted in deceased donor transplant list. 2 children had deceased donor transplant done. About 30 children transplant evaluation was not initiated. 10 children had medical problems, but even when 20 children who didn't have medical problems refused treatment or delayed decisions. So they came to conclusion that the major barriers in kidney transplantation in children is the denial or poor awareness of chronic kidney disease, predominant paternal decision making, where in our family where patriarchy is supreme, mothers don't have a say on decision making, financial hardship, and very importantly, negative attitudes toward organ donation. So now when we discussed these barriers about kidney transplantation in children, now discuss how to overcome these barriers. I would like to share our experience in Gujarat and how the system in Gujarat has helped in kidney transplantation in lot of underprivileged children. So I work at IKDRC ITS, which is the only state institute offering kidney transplantation or end-stage kidney care in the state. Along with Government of India and Government of Gujarat programs, we have two good programs, Gujarat Dialysis Program and School Health Programs. We are now offering end-stage kidney failure treatment to almost all children in the state, whoever are coming to the institute. To say a few word about Gujarat Dialysis Program. So as per this Gujarat Dialysis Program, IKDRC ITS is the nodal institute, and we have the funding is by Government of Gujarat, and we have established peripheral dialysis center almost in all districts, and it is attached to district healthcare center. The establishment of center and treatment, water treatment plant, training of the employees, employment, salary of the technicians, logistics, etc., all are managed by IKD. Also, Government of Gujarat funds not only the dialysis, it funds the EPO, iron, multivitamins, etc. And currently, about 30 children are getting dialyzed at peripheral centers. This has helped a lot in improving the end-stage kidney care in children, because as we discussed earlier, distance is a major factor, and if they don't have to travel large distance, they usually continue with the treatment and don't drop out. The other program is a school health program. It is also combinedly funded by Government of India and Government of Gujarat, where all the children who are less than 18 years and have Gujarat domicile get free of cost treatment at IKDRC ITS. There is no restriction to family income or poverty status. So it covers all the conservative care of kidney failure along with dialysis on preparatory investigations like HLA typing and single antigen screening, and transplantation and surgery, post-transplantation care, post-transplant medications like ATG, rituximab, IVIG, etc. So when we analyzed, we found that in last 7 years, about 190 children got transplanted with per patient expenditure of US dollar of 3,341. That comes to roughly to around 2.5 lakhs per patient. Around 45 children got transplanted during this COVID pandemic itself. So looking at the outcome of the kidney failure seen in children seen in at our center since January 2020, we saw around 217 patients, around 20% expired, and 15% got lost to follow-up. 46 children got transplanted, 18 deceased donor transplant, and 46 living donor transplants. We lost 4 grafts, 1 to thrombosis, 1 to FSGS recurrence, and 2 ABMR. 3 children died, 2 due to sepsis and 1 due to graft failure. 16 children had acute rejections and 6 had viral infections. So to summarize how to overcome barriers, as elaborated in the previous slide, we will discuss the major barriers. So the first major barrier is the denial, poor awareness. Yeah, so here we can create awareness about care of kidney failure in children by government, by various NGOs, civil societies, etc. The primacy of paternal decision making. We can talk to the family, we can do counseling, and we have to take the mother into confidence. For financial hardship, state support is needed. NGOs also can chip in and help in these to this family. And most important is the negative attitude towards transplantation. This one I want to stress here, because here as transplant coordinators, we can do a lot more. We can create awareness, we can talk to people, we can talk to family, and help in alleviating this negative attitude towards transplantation. And of course, gender is a very important barrier. And as Government of India is undertaking Beti Padhao, Beti Bachao Abhijan, so increasing education of mothers this and increasing awareness about